Imagine you're standing in a pitch black room. There's furniture in there, maybe some like fragile obstacles, but you literally cannot see a single thing.
Right, just total darkness.
Exactly. So you turn on a flashlight, you sweep that beam of light around, searching systematically until the layout of the room finally starts to make sense and you can, navigate safely without breaking anything.
It's honestly such a profound clinical metaphor.
hmm
Because without a methodical way to direct that light, you're stumbling in the dark, reacting blindly to whatever you bump into
And
first.
reacting blindly in medicine causes harm,
Absolutely. It causes immense harm.
which is pretty much the core philosophy of our deep dive today. We're welcoming you, whether you're a medical student prepping for rotations, a resident fine-tuning your diagnostic skills, or just, a dedicated learner trying to master the architecture of the human mind.
It's a complex architecture.
It really is. Our mission today is to comprehensively unpack the frameworks within psychiatry, clinical cases uncovered by Peter and Nicola Byrne. And psychiatry, as the sources make incredibly clear, demands this unique, almost daunting integration of biological, psychological, and sociological data.
Yeah, it's the ultimate clinical specialty. It demands that a clinician navigate the invisible.
Right.
But before we even get into the diagnostic frameworks and the real-world cases, we need to establish a critical, non-negotiable ground rule. Diagnoses describe disorders, not people.
Meaning, like, a patient on your ward isn't a schizophrenic, they are a person presenting with schizophrenia.
Exactly. And that distinction goes far beyond just semantics. It fundamentally anchors your clinical judgment.
How so?
Well, when you conflate the person with the pathology, you lose clinical objectivity and you risk diagnostic overshadowing. Maintaining that separation allows a doctor to use structured, highly systematic thinking while, preserving an active cognitive empathy.
Okay, let's unpack this. Because before you can treat a patient or even empathize effectively, you have to actually know how to investigate their symptoms.
Right.
And that brings us to the absolute backbone of psychiatric assessment, the diagnostic hierarchy.
If you internalize literally nothing else from this discussion, let it be the diagnostic hierarchy. When evaluating a patient with new onset psychiatric symptoms, you must aggressively rule out physical organic pathology before you even entertain the idea of a primary psychiatric disorder.
Let's walk through the actual flow of that hierarchy because the order is highly intentional, right? It goes organic illness first,
Always.
then substance misuse, then psychotic disorders,
Mm.
followed by mood disorders, then anxiety disorders, and finally, sitting at the very bottom, personality disorders.
The rationale behind that descending order is based on acute severity and etiology. You start at the top
Right.
because organic illnesses and substance intoxication are acute exogenous insults to the brain.
Like outside forces attacking the system.
Exactly. If you miss them, the patient could die. We put psychotic disorders above mood disorders because a severe psychotic episode completely ruptures a person's reality testing, which often masks underlying mood symptoms.
Oh, that makes sense.
Yeah, and personality disorders are at the bottom because you just cannot accurately assess a lifelong ingrained character structure, while a patient is, acutely manic, hallucinating, or in alcohol withdrawal.
Let's look at how disastrous it is when a clinician ignores the top of that hierarchy. Imagine case one from the book, a 20-year-old student, Ishmael, who suddenly collapses in a supermarket.
Right, a very common emergency presentation.
His heart is racing, he's sweating, he feels a crushing sense of doom, and he's hyperventilating. I mean, it looks like a classic panic attack.
It certainly presents as autonomic hyperarousal. But following the hierarchy, you cannot jump straight to anxiety disorder.
You have to clear the organic tier first.
Exactly. You must check cardiovascular, neurological, and endocrine function. You run a comprehensive metabolic panel, check thyroid-stimulating hormone, do an ECG, and run a toxicology screen.
Because hyperthyroidism, a cardiac arrhythmia, or even acute stimulant intoxication can perfectly mimic panic disorder. If you just hand him a paper bag to breathe into and a psychiatry referral, you might be sending home a patient in ventricular tachycardia.
You're touching on a crucial distinction there. The brain is a biological organ. It reacts to biological insults. Consider an entirely different demographic from case 5. An elderly woman in a nursing home who suddenly becomes deeply confused, highly agitated, and starts experiencing visual hallucinations.
If a doctor bypasses the hierarchy and jumps straight to the middle, they might label that late-onset schizophrenia.
Which is terrifying, because prescribing a heavy dose of typical antipsychotics to a fragile elderly woman could induce severe side effects or even be fatal.
When really her sudden behavioral shift is almost certainly delirium, right? Secondary to an acute organic infection like a chest infection or UTI.
Precisely. In an elderly patient, the systemic inflammatory response from a simple bacterial infection completely disrupts cerebral metabolism. It alters neurotransmitter synthesis, leading to an acute confusional state. You don't treat her with antipsychotics, you treat her with antibiotics.
It really emphasizes that being a psychiatrist means you actually have to be an exceptional general physician first. You're a medical detective ruling out the physical suspects before interrogating the psychological ones.
What's fascinating here is that missing a physical cause means you're missing an entirely treatable pathology. That is exactly why those initial blood panels, checking calcium levels, thyroid function, inflammatory markers, are just non-negotiable first steps.
So let's assume we've meticulously navigated the top of the hierarchy. We've run the labs, cleared the ECG, definitively ruled out organic causes and substance misuse. Now, how do we systematically measure the mind itself?
We rely on the mental state examination, or the MSE. The MSE is basically the psychiatric equivalent of a physical exam. It's a highly structured snapshot of the patient's mind at that specific moment. You're observing domains like appearance and behavior, speech, mood versus affect, thought content, perception, cognition, and insight.
For our listeners who are already familiar with the basics of the MSE, I want to drill down into the nuances that actually trip clinicians up. For instance, evaluating mood versus affect.
It's a classic stumbling block.
Yeah, we know mood is the patient's subjective emotional baseline, and affect is the clinician's objective observation of their emotional responsiveness. But the critical diagnostic clue isn't just identifying them, it's looking for the discordance between them.
That discordance is a massive red flag. If a patient reports their mood as devastated because they just experienced a major trauma, but their affect is completely blunted or worse, incongruous.
Like smiling or laughing inappropriately while detailing the trauma.
Exactly. That points toward a severe affective flattening, often seen in the prodromal phase of schizophrenia, or severe dissociation, rather than just uncomplicated depression.
Another massive clinical trap in the MSE is within thought content differentiating between an overvalued idea and a true delusion. In a high-stress environment, they can look identical.
They really can. But confusing them alters your entire treatment trajectory. Both involve deeply entrenched beliefs. An overvalued idea is held with intense conviction, like a patient with severe anorexia who genuinely believes they are dangerously overweight despite being emaciated.
It dominates their life, but it remains a distortion of a conceivable reality.
Right. A delusion, on the other hand, is a fixed, profoundly false belief that represents a complete break from reality. It's maintained despite absolute, incontrovertible objective evidence, and it's entirely out of keeping with the patient's cultural background.
Which brings us to cognition. The clinical frameworks we're discussing highlight an incredibly elegant neurological test for this, the clock drawing test. You simply ask the patient to draw a clock face and set the hands to 3.45.
The beauty of the clock drawing test lies in its neuroanatomical density. It is far more than just a simple memory check.
Oh, definitely. You're testing parietal and frontal lobe integrity simultaneously. When they draw the circle and place the numbers, you're checking the right parietal lobe for spatial construction and neglect, like, did they cram all the numbers onto the right side of the clock?
And when you ask them to set the hands to 3.45, you are heavily taxing the frontal lobes.
Because they have to inhibit the impulse to draw them in hand pointing at the number 4, right?
Exactly. You're checking executive function, abstraction, and strategic planning, because they have to abstractly calculate his placement at the number 9. It yields an immense amount of cognitive data in about 30 seconds.
But gathering data through the MSE is only the first half of the job. A list of symptoms is practically useless without a clinical formulation.
Yes. You must synthesize that data using a structural framework, specifically the 3x3 etiological grid.
Let's map out that grid. On the vertical axis, you categorize the data into biological, psychological, and social factors.
And on the horizontal axis, you map those domains across time. Predisposing factors, precipitating factors, and maintaining factors.
Breaking it down chronologically gives the symptoms context. Predisposing factors are historical vulnerabilities. Biologically, maybe a family history of bipolar. Psychologically, childhood trauma.
Precipitating factors are the immediate catalysts, the match that lit the powder keg. Socially, an eviction, biologically, maybe a new medication.
And the maintaining factors are what's actively preventing the patient from recovering right now, like ongoing substance abuse or severe financial destitution. So what does this all mean?
It means the 3x3 grid fundamentally forces a physician to stop label slapping. It answers why this specific patient is presenting with this specific pathology at this exact time.
Because if you only treat the precipitating biological factor but ignore the maintaining social factors, like sending a stabilized patient straight back into homelessness relapse is inevitable.
Completely inevitable.
Armed with the MSC and the 3x3 grid, let's navigate into the heavier territories of the hierarchy, psychosis and mood disorders, and how they shift across the lifespan. Let's look at case 3, Robbie.
Robbie.
He's an 18-year-old student showing the classic prodrome of schizophrenia, social withdrawal, dropping grades, flat affect, paranoia. But his history reveals heavy cannabis use.
The cannabis introduces a profound diagnostic complication. THC interacts directly with the brain's endocannabinoid system, modulating dopaminergic pathways.
And the dopamine hypothesis of schizophrenia tells us that overactivity of dopamine drives positive psychotic symptoms.
Exactly. Heavy cannabis use can independently trigger a drug-induced psychosis that is clinically indistinguishable from primary schizophrenia in an emergency setting.
So how do you formally separate the two?
Time and abstinence. To confidently diagnose a primary psychotic disorder, you generally need to observe the patient over at least 1 month of complete abstinence. If the psychosis clears, it was likely substance-induced. If it persists without the cannabis, you're looking at a primary psychotic disorder.
Now contrast Robbie with Rose from case 6, a 72-year-old woman who barricades herself in her apartment because she's convinced her neighbors are pumping toxic gas through the vents, no psychiatric history.
This highlights late-onset schizophrenia, presenting after age 60. The pathophysiology often involves sensory deprivation.
Like deafness or vision loss.
Yes. When the brain is starved of clear sensory input, its pattern recognition software goes into overdrive trying to fill in the gaps. It misinterprets ambiguous environmental noise, like a radiator hum, as a direct persecutory threat.
And therapeutically, her age dictates a completely different approach from the 18-year-old. Her hepatic and renal clearance rates are diminished, so she requires much lower doses of antipsychotics to avoid severe toxicity.
Precisely. Geriatric psychiatry requires incredible pharmacological caution. And this principle applies equally to severe mood disorders. Let's look at case 7, Sajida. Severe depression presenting with catatonia. She's mute, immobile, and has stopped eating and drinking.
The intervention indicated here is electroconvulsive therapy, or ECT. But ECT has such a stigma. How do you explain its use to a skeptical patient or family?
If we connect this to the bigger picture, you approach it by explaining the absolute physiological peril the patient is in. Severe treatment-resistant depression with catatonia is a medical emergency.
Because if they refuse all fluids, they'll rapidly progress to renal failure and cardiovascular collapse.
Exactly. Standard antidepressants take 4 to 6 weeks to work. This patient does not have 6 weeks. She has days. ECT is highly effective and sometimes life-saving because it provides a rapid neurobiological reset.
Inducing a controlled seizure under general anesthesia to release neurotransmitters.
Yes, the doctor has a duty to clearly explain the risks, like transient memory loss versus the high risks of the untreated illness. In these cases, it is unequivocally life-saving.
On the opposite end of the mood spectrum, we have Declan, case 20, a 21-year-old medical student whose arrogant, boundary-crossing behavior on the wards contradicting attending, staying awake for days, looked like pure narcissism.
But when you process those observations through the MSE, the underlying pathology becomes obvious. His boundary violations are grandiosity. His days awake are a biological decreased need for sleep. He's experiencing bipolar mania.
Recognizing that biological driver behind the behavioral disruption is paramount, which brings us to the hidden battles. Because psychiatric distress doesn't always look like psychosis or severe depression. Sometimes it hides in physical complaints.
Medically unexplained symptoms.
Yeah.
Like Tara in case 19, a 32-year-old woman who visited her GP relentlessly for 11 years with myriad physical complaints, resulting in 5 normal MRI scans.
We have to differentiate somatization disorder from conversion disorder here. Conversion is an acute trauma converted into a sudden loss of motor or sensory function like sudden blindness. But Tara is demonstrating somatization.
Right. In somatization, the patient chronically experiences real physical distress driven by psychological anxiety. They aren't faking it. The nervous system is genuinely amplifying somatic signals, often leading to unnecessary harmful medical procedures.
So you don't just dismiss them and say, it's all in your head.
No, the treatment is to shift the focus. Establish a single prescribing clinician, usually their GP, with regular brief appointments. This prevents polypharmacy and surgical fishing expeditions. Over time, you validate the physical distress while gently steering toward the psychological stressors.
It's about containing the anxiety. This kind of diagnostic masking happens with younger patients too, like Miguel in case 9, a 9-year-old with a low IQ who harms animals. The differential is ADHD versus conduct disorder.
And that differentiation alters his life trajectory. Conduct disorder involves intentional violation of societal norms. ADHD involves impulsivity and executive dysfunction. Factor in his low IQ, and his destructive behavior isn't psychopathy, it's profound frustration. He lacks the cognitive architecture to process demands, resulting in chaotic acting out.
Here's where it gets really interesting, particularly regarding diagnostic overshadowing. Consider Tony, case 8, a 17-year-old cutting his arms. The reflex is to assume teen angst or bullying, but buried in his history is a prescription for isotretinoin, or Roaccutane, for acne.
This raises an important question about diagnostic overshadowing. Isotretinoin operates on pathways that affect dopaminergic and serotonergic systems. In a vulnerable subset of patients, it's a known biological precipitant inducing severe low mood and self-harm.
If you let the dramatic psychological presentation blind you to the biological reality, you might commit him to a psychiatric facility instead of just stopping the acne medication.
In both children and adults, with learning disabilities or physical ailments, you must not let the obvious issue blind you to underlying pharmacological or environmental triggers.
So we've diagnosed the problems using the hierarchy and the MSE. Now, how does the book tell us to fix them? The text provides an A to Z mnemonic of biopsychosocial treatments. Let's rapid fire through the key ones.
Let's do it. A is for assessment. A good assessment is actually therapeutic in itself. It helps the patient see their symptoms in context, which actively lowers anxiety.
B is for behavioral therapy. A core intervention is the specific slow breathing exercise for panic. Breathe in for 4 seconds, hold for 2, out for 4.
Right, because hyperventilation causes you to blow off too much CO2. By pacing the breath, you stop the hyperventilation cycle and chemically short-circuit the autonomic panic loop.
C is for cognitive therapy, specifically CBT. Identifying negative automatic thoughts, or NATs, and challenging dichotomous black and white thinking.
And D is for drugs. The clinical rule prescribing is start low and go slow, especially in the elderly and those with learning disabilities.
You have to closely monitor plasma levels for mood stabilizers like lithium, right?
Yep.
Because its therapeutic window is incredibly narrow.
Exactly. You don't just prescribe and walk away.
Treating psychiatric disorders is honestly like maintaining a complex ecosystem. You can't just throw a chemical at it, the drugs part. You have to adjust the environment with social or occupational therapy, repair the internal logic with cognitive therapy, and sometimes involve family interventions to prevent relapse.
It's the ultimate orchestration of biopsychosocial medicine.
It really is. As we synthesize all this, we have to acknowledge that psychiatry relies on empathy.
Empathy is an active process of accurate identification with a patient. It is not to be confused with sympathy, which is just pity. Empathy allows you to understand their distress while maintaining objective clinical distance.
Which leads to a final provocative thought for you, our listener, to mull over. The book outlines the duties of a doctor, which includes not just prescribing, but advocating for marginalized patients who face immense societal stigma. How will you use your medical knowledge to combat the deep-seated prejudices against mental illness in your own future practice or daily life?
Knowledge without advocacy is incomplete.
Very true. Now, as promised for our medical students and dedicated learners, here is a final review question to test your attention of today's deep dive. Based on the diagnostic hierarchy we discussed at the very beginning, what is the absolute first category of illness you must rule out when a patient presents with new-onset psychiatric symptoms, and why?
Take a brief moment to formulate your rationale.
The answer is organic and physical causes. Because missing a physical pathology like an infection or tumor can be life-threatening, and it is entirely treatable.
You must sweep your clinical flashlight across the physical landscape before you ever attempt to map the psychological one.
Thank you for joining us on this deep dive. Apply these structured clinical frameworks to your own continued learning, and we'll see you next time.